Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so that you can connect to your profession. Today, Leah will chat with returning guest Erin Locati and discuss her journey to PT in the high-risk pregnancy unit, how to adapt to activity restrictions, and using manual therapy in acute care. Let's welcome our guest.
On today's show, we have a returning guest, Erin Locati, who is coming from San Antonio, Texas. Erin, what's the weather like in San Antonio right now?
It is warm. It is 70 right now. At 10 a.m. It's going to go to 88.
And most people
in March.
Right, and most people say, "Oh, that sounds like great like summer weather." But how does it get in actual summer in San Antonio?
It's going to go over 100 degrees. Yeah, we keep setting records every summer for how many days in a row we're over 100.
Wow. Well, awesome. Welcome back to the podcast. Last couple times you've been in the podcast, I think we were talking about the value of physical therapy, especially with the peripartum and postpartum populations. Mm-hmm. We want you here today to kind of talk about maybe a couple cases and maybe more specifically about you and how you even got involved with this patient population. But even taking a further step back, how did you even get involved with physical therapy in the first place?
So I actually went to college to be an engineer. I majored in chemical engineering.
Really?
And yeah. And then because my mom's a chemical engineer and she's really good at it and she loves what she does. So I thought maybe I'll like that. But then I did my internship that you do towards the end of your college career in engineering and went, oh no, I don't want to do this. I don't want to do this. And so I started to look into, well, what else could I possibly do? I mean, I substitute taught because I thought maybe I'd like being a teacher. I volunteered at different places, including a physical therapy clinic. I volunteered there and thought, well, I really like this. And that's kind of where I started getting into physical therapy and then decided I was going to go to PT school.
Was that an outpatient clinic or inpatient clinic?
It was outpatient, like outpatient sports ortho kind of
I
place.
see. I see. That's interesting because because my brothers are both engineers, when I think about them and their daily interactions, their personal interactions are very different compared to the communication, the personal interactions that you have as a therapist. So that's an interesting switch. And then once you got into PT school, when did you start to find out that there's this actual setting called acute care? Because I had no idea when I first started in PT school about what acute care even was.
I agree. I mean, because I did my volunteer hours mostly in outpatient. I did do a little volunteer in the hospital in acute care, so I knew it existed. But when I went into PT school, I thought, oh, that's not going to be me, right? Like I was very much, I'm going to be the sports ortho PT, right? Which I think a lot of people go into PT thinking that, especially if they or a family member has had an experience with outpatient physical therapy sometime during their life before PT school.
Right.
But then I did my acute care rotation and I was in the ICU with the ICU therapist. So it was very complex. And I was like, wow, there's just so much here that is so much more than I thought acute care was, right? I really thought of acute care as being you walk patients, right? And it's sort of I know when I went to PT school, I did have a bias that acute care was sort of the lesser skilled setting, right? That the really badass, knowledgeable therapists go into ortho. Right, like outpatient ortho. And when I did that ICU rotation, I realized, oh no, I mean, you could kill somebody here if you don't know what you're doing, right?
Absolutely.
In an ICU setting, you really need to be on top of your skill and your knowledge with a lot of diagnoses, right? A variety of different things. And then after that, I did an inpatient rehab where you do 3 hours a day of therapy rotation. And I really enjoyed that also because I was getting to work with a lot of different diagnoses. And you get to work with them for an extended period of time, which I enjoyed. And there was just something very fulfilling in both acute care and rehab settings about the idea that these people really want to go home and they can't, right? They have these physical barriers that are keeping them from going home, and you're a part of solving that for them so that they can get their life back in a really meaningful way. Not that you're not helping people get their life back in outpatient also, but it just feels like it's at a different level when getting your life back means literally just being able to go home.
Right. Like, how are you going to manage just getting into the house? Okay, what does your house look like? How many stairs in? Oh, the bathroom is on that floor. The bedrooms are on the second floor. And those are real problems that where I think is great is that our interventions can affect the actual patient, right, and some of their impairments, whether it's strength, but our interventions can also
Hmm.
kind of target the environment. Is there some
Yeah.
environmental changes? And that's where I think that's where there's some fun creativity that we get to do as physical therapists. Now it's interesting that you had great exposure in the critical care side of things, and you were able to witness firsthand the skill that gets involved. Now
Mhm.
fast forward to what population are you working with now, and obviously those skills are gonna come into play. So what patient population are you specializing in now?
So my specialty now is high risk pregnancy patients that are admitted to the hospital. So these are people who are pregnant and have a serious enough problem or complication with their pregnancy that their doctor feels they need to be admitted to the hospital for
Hmm.
some period of time for closer monitoring or higher level interventions. And then I also specialize in super early postpartum care. So after you've
Hmm.
had your baby, before you go home from the hospital. So kind of that first 24 to 72 hours after delivery. I really like seeing people in the acute setting for that. Mhm.
Interesting. And so you're the dedicated therapist for that patient population?
So at my current hospital, I'm the only person who specializes in that, but it's a brand new hospital. So the plan is to not only for me to ramp up over this year, seeing more of the patients we have in those units, but then also training other therapists so
I
that
see.
it's not just me. They can see them.
Now, do you know of any other hospitals or hospital systems that have this? I'll say from my experience, I was working in a small community hospital,
Mhm.
and it was kind of few and far between. Like that physical therapy in the peripartum and postpartum unit, labor and delivery was not standard. It was usually, for the most part, somebody that is pregnant has some back pain and it's some acute back pain, then they send us. That would literally happen maybe once a quarter, or a
Mhm.
situation that post delivery maybe they have some impairments. Maybe there's a nerve injury, there's numbness and tingling
Mhm.
down one leg, that falls risk. Can you come in
Yeah.
and do some gait training? But definitely isn't standard. So are there other places that have it as standard practice?
So there is another big hospital system here in San Antonio that does have some therapists that will go see high risk patients and postpartum patients. I wouldn't say it's standard like everybody's getting it. One of the big barriers is really staffing, right, in acute care,
Mm,
right, to add on a bunch more patients and then also having therapists that have enough expertise in this area to see them. But I know here in Texas, in Houston, there are two big hospital systems that it's much more common. And there are a growing number of hospitals that are offering it all over the country. There's a website actually you can go to called Enhanced Recovery After Delivery that has a hospital directory on it
mhm, mhm.
where you can look up hospitals that are providing PT or OT services in high risk pregnancy or in postpartum units in their hospitals to see if there's one near you. Mhm.
Mhm. I mean, that benefits both therapists and just
Yeah.
even just the general public to know that there are, therapy services
Hmm.
that would be available. So how did you come across this patient population? Were you working in acute care first, and you were just like, there's this need. I kind of like this population. There's a lot that we can, and people are not addressing this. So, kind of, how did you end up in that situation?
So I was already working in acute care and I really liked acute care. I got pregnant with my kids, and after both of them, I had birth injuries. I had tearing, I had pelvic organ prolapse, I had postpartum depression, I had a lot of issues with breastfeeding, and it really just felt like I kind of walked off a cliff in the healthcare system
Mm,
after I had my kids. Because when you're pregnant, you go see your doctor at very regular intervals, but then after you have your baby, you don't see anyone until a month and a half, 6 weeks after you've had your baby, and then you see them one time, and then you don't see them again. So I really
mhm,
felt alone navigating kind of my
mhm,
postpartum recovery and my injuries and return to activity and exercise.
mhm,
And
mhm,
then during my second pregnancy, I was diagnosed with a couple serious complications. And again, I just really felt alone and frustrated and not really knowing, well, what is it safe for me to do? I don't want to accidentally hurt my baby by doing too much. And my doctor
mm,
wasn't super helpful about it.
mhm,
So I knew that pelvic physical therapy was a specialty that existed
mhm,
where
mhm,
PTs work with pregnant and postpartum patients, but it was really more of an outpatient specialty as far as I knew.
mhm.
And I was in acute care and I wanted to stay in acute care.
Yeah,
So
yeah.
I thought about, well, how can I help these populations where I am? I mean, all these patients are here in the hospital. Almost everybody gives birth in a hospital in the US. So maybe there's a way that I can provide skilled care in the setting I'm already in to pregnant and postpartum patients. And that's really where
Mhm.
it started. And that was 8, 9 years ago now.
Wow.
Hmm.
Very cool. And so what
Hmm.
what interventions do you feel that are would have the biggest impact on this patient population? You had mentioned a couple of things, right? Like, can you exercise in terms of the peripartum right
Hmm.
before delivery? Like, can you exercise? What's the limits? Is there somebody that, and
Hmm.
who better than the physical therapist to be able to kind of give that information? So that's one part. And then, like you said, there was some post-birthing, there were some complications in terms of injuries that you sustained. And you think
Hmm.
about any other time that you come to the hospital for any type of procedure, right? Whether it's broken hip, torn shoulder, post-operative.
Hmm.
Physical therapy is standard practice, right? It's just kind of like part of the
Yeah.
standard order set. But still, even though we've mentioned this
Yeah.
before, after birth or C-section or anything regarding attempt birthing injuries, I don't think that physical therapy is automatically part of the conversation, right? So just in
Mhm.
terms of your opinion, what are the biggest interventions that you see as having an impact in this population?
So for high risk patients, I do think one of the biggest interventions you can provide is if their doctor has given them some type of activity restriction, so
Hmm.
told them they can't do certain activities or that they need to be in bed for a certain amount of time every day, is making sure that they understand what their doctor's restrictions are, just
Hmm.
like we would make sure somebody who has a weight bearing restriction understands it. Right. I mean,
Right.
I've definitely gone into a patient's room who has been told they're non weight bearing on their foot after surgery, and they're walking to the bathroom when I get there with no assistive device, and they're just kind of dragging the leg behind them. And I tell them, "Oh, you can't put weight on it." And they go, "Oh, I'm not putting weight on it." And they're just dragging it behind them. And I'm like, "Oh, but you are, right?" And you can't just take for granted that because a healthcare provider gave you some restriction, right? Whether it's weight bearing or a larger activity restriction, that the patient fully understands what that restriction means for how they're going to live the day of their life. How am I going to get out of bed? How am I going to get to the
Hmm.
bathroom? How am I going to do my ADL tasks? Right?
Hmm.
How am I going to do my work tasks if I'm going to return to work? You can't just take for granted they know how to do all that. So, really taking the time to walk through, well, what does your day to day look like? And how can we fit in the tasks that you need to do or that you really want to do into
Hmm.
whatever your level of restriction is, to
Hmm.
allow you to be able to really do as much of your life as you possibly can, like up to the limit of your restriction.
Right.
I
Right.
think that's one of the most valuable things that we can give people, and also teaching them signs and symptoms to look for that could indicate that maybe they are overdoing it, right?
Ah,
Because I'm not necessarily going to be able to go through every single thing you could possibly do with your body,
right.
right?
Right.
And is that a yes or is that a no for you?
Mhm.
So teaching them what to look for to know, oh, I should rest, or oh,
Right.
I should call my doctor, or oh, I should call the OB hotline.
I mean, that's
Mhm.
funny because that's I never even thought about this. Is that
Yeah.
nurses or discharge planners or the doctors that might say, okay, you're non-weight bearing. It's easy to say, and of course, in a
Mhm.
conversation where it's just kind of communicating and we're just speaking. Okay, you're non-weight bearing. Do you understand that? Oh yeah, I understand that. But once you
Yeah.
put it into practice, what does that mean when it's 2 o'clock in the morning and they need to get up and use the bathroom, and the bathroom is 20 feet away? What is non-weight bearing? So to actually see what it
Mhm.
means getting in and out of bed.
Yeah.
And again, there's some room. Patients are very creative, right? Like, oh yeah, I'm not putting weight on it, but like your foot is on the floor. I think
Mhm.
we've got some discrepancy in terms of the operational definitions of what is not. That means like it should not be touching the floor. But in a conversation with like a nurse, okay, these are your meds, X, Y, and Z, or
Mhm.
maybe with a surgeon, you're non-weight bearing. Do you understand what that means? Yeah, don't put the foot on the floor. Okay. But once you start actually moving around, a little bit of a different story. Now, I think it's
Mhm.
interesting too that you had mentioned, if you mention a bed rest to an acute care physical therapist, we know the plethora of literature of why that's not a good thing. And you had mentioned
Mhm.
in some of our conversation that you've worked with patients that maybe they had their last maybe hip replacement or knee replacement decades ago, and they're expecting that they're going to stay in bed for 3 days. Like, no, we start moving around day of if we can. But I think that's interesting that there's all this literature that shows the benefits of early mobilization, but yet
Mhm.
it's almost like this postpartum group kind of get left behind in the times. Like we still say, or even peripartum, you need to be on bed rest. So how can a physical therapist maybe I don't want to necessarily say challenge, but what's your opinion on that in terms of those bed rest restrictions?
So I would say bed rest restrictions are, you're typically going to see that potentially for someone who has a serious complication with their pregnancy.
Hmm.
So if you don't have a complication, the current recommendation, this is probably what your OBGYN doctor will tell you, is that you should be exercising during pregnancy. We know that
Hmm.
it has a
Hmm.
lot of benefits for mom and baby to be
Hmm.
physically active during pregnancy. And then in postpartum, they're going to encourage you to get up and start walking to minimize your blood clot risk, and,
Hmm.
and also so that they can discharge you quickly
Right, right,
from
right.
the hospital, right? They want you to be up and walking. They want you to be having bowel movements. They want you to
Hmm.
be going to the bath, peeing, so that they can discharge you as well.
Hmm.
But that group that has complications, all of that kind of grinds to a halt for them during their pregnancy. So
Hmm.
currently, around like 90% of providers will prescribe some type of activity restriction, like they're
Hmm.
willing to do that, and it happens in about 20% of pregnancies. So that's 1 in 5. I mean, that's a lot of moms that are being
Hmm.
told, not necessarily bed rest, but some level of, you need to pull back on whatever you're doing. And the most severe form of that would be being told you need to be on bed rest. And
Hmm.
like you said, we know as therapists all the negative consequences that come for your body when you're
Hmm.
on bed rest. And that applies to pregnant patients just like anybody else, right? They're going to
Hmm.
have loss of muscle mass, bone density, increased risk of blood clots, decreased cardiopulmonary endurance. They're also missing out on the benefits of activity for themselves and their baby during pregnancy because of that. And historically, the reason why these restrictions, especially like bed rest level, were given to patients with complications is the thought was severely decreasing your activity would increase the length of your pregnancy, right? It would
Hmm.
decrease the chance that you would have your baby early, or that you would have a serious problem like start hemorrhaging, right?
Hmm.
Which could
Hmm.
be fatal to you or your baby. And it's really hard to do research in this population, right? Because you don't want to accidentally do harm to someone or their baby by putting
Right.
them in the intervention group where
Hmm.
they're going
Hmm.
to continue living their normal life and not restrict their activity at all. And then something bad happens.
Hmm.
However, over time, we have started to be able to gather more and more data, and there are more and more papers coming out that are
Hmm.
examining, well, what happens when people don't do these stricter activity restrictions or don't do bed rest for these complications. And it turns out that it looks like the restrictions don't really meaningfully improve pregnancy outcomes.
Hmm.
So, in
Hmm.
terms of how early you have the baby, or complications for the baby, or complications for mom, it turns out it doesn't really seem to make a difference. So organizations like the American College of Obstetrics and Gynecologists, it's kind of like APTA for
Hmm.
OBGYN doctors in the US, and the Society for Maternal Fetal Medicine, those are doctors who specialize in high-risk pregnancy. Their recommendations have been evolving over time, and their current ones are that they actually recommend against activity restrictions and bed rest for a number of different complications
Wow.
that they're often prescribed for,
Hmm.
because the evidence shows it's not really helping the thing we want it to help, but it's also not a harmless intervention, right? That bed
Right.
rest, that
Right.
activity restriction has all those negative physical consequences, it has negative psychological consequences. It can even
Hmm.
have negative financial consequences if you can't go to
Absolutely.
work anymore. I mean, that
Right.
happened to me in my second pregnancy. I was an acute care PT and was told, you can't exercise, you can't lift anything heavy. Those are core parts of my job duty, right? Like if
Right. Right.
I have to be able to transfer people, or if somebody falls, I have to be able to catch them. So I
Hmm.
suddenly couldn't work in
Hmm.
the middle of my pregnancy, which I wasn't planning on, right? Like I
Right.
was saving my leave for postpartum, and now all of a sudden it's happening right now at like 18 weeks into my
Wow.
pregnancy. So it really has a lot of knock-on effects in every area of your life that are harmful to you. And if it's not benefiting you, why are we doing it? But
Right.
then I think that the difficult part comes in, well, it's still prescribed in around 20% of pregnancies.
Hmm.
When they survey OBGYN doctors, 90% of them say that they still prescribe them to some number of their patients,
Right.
right? So, and in the antepartum unit in the hospital, pretty much everybody has activity restrictions. I even saw somebody last year who was on bed rest in Trendelenburg position, so with her
Wow.
head below her feet, and
Wow.
she had to roll on her side to eat or to use a bedpan, and she was like that for weeks.
Oh my
So,
gosh.
yeah, I mean, that's much less common today, but it's still happening,
Yeah.
so how to have conversations with providers, it's tricky, right? I
Yes.
do think
Yes.
that, if they're open to reading some of the papers that are coming out, or position statements from professional organizations around it, that can be helpful. but I think it's a hard thing to let go of because there's a lot of fear when you
Yeah.
have a pregnancy complication. If you don't want to get out of bed after your hip replacement and want to just rest in bed for 3 days, it's harmful to you, but it's
Hmm.
not harmful to anybody else.
Hmm. Hmm.
But when you're pregnant, there's the fear that, well, I could hurt my baby, and I am willing to suffer a pretty large amount of negative consequences to me personally if it'll keep my baby safe.
Right, right, right,
So patients and doctors are much more willing to accept all of the negative consequences of activity restriction if there could be even a small chance it'll help the baby.
right, right.
So how do you get past that? It's hard because and it's hard to tell someone you have a complication and there's nothing we can do,
Mm,
right? We just have to
mhm.
let the pregnancy play out, and activity restriction won't change your outcome. Telling them, "Hey, if you stay off your feet, that might help." It's giving you and the patient something to do
Right,
to
right.
maybe help this really overwhelming complication that you have.
Right. And who better
Mhm,
than the acute care PT to be able to supervise that and to be able to kind of
mhm.
give cues and to give education, maybe in terms of posture, just in terms of,
Yeah.
what's the safest way in terms of their mobility and to get from point A to point B, or maybe even just getting out of bed. Some of
Mhm,
those simple tasks that we kind of take for granted. But who better than the acute care PT to be able to be right there in that hospital room to start addressing those things. It is interesting
mhm,
that it's great that there's literature that's coming out that's supporting the value of what we can do, although it's sparse as I understand it. But there's again there's
mhm,
some literature that's coming out. But I also feel that a lot of people, they're just stuck in the same old patterns in terms of like, oh, this is a complication.
mhm,
We're gonna put the person on bed rest, and to challenge those kind of those patterns that have been wired for such a long time
mhm,
can be difficult. So my next question then is kind of like, what are the barriers that you see in terms of physical therapists, acute care PTs
mhm,
working with this population? How do you have that? How do you tactfully have that conversation with the doctor that is saying, okay, person's on bed rest, and they don't see any value up front in terms of what the
mhm,
physical therapists do? How do you tactfully maybe engage in a conversation? And this is a great subject, even if you're in acute care physical therapy and you're not working with this specific population. There are going to be times where you're going to have to engage in conversations and get buy-in from doctors, nurses, case managers in terms of the value that you bring. So, Erin, what advice do you what do you have for our audience that are challenged by this?
So it's definitely a barrier with physicians. I mean, they don't even think to order physical therapy in high risk
Right.
pregnancy or even in postpartum, right? Like it just
Mm-hmm.
hasn't been part of the standard of care historically, right? So
Mm-hmm.
there's a barrier there of just letting them know, hey, we exist and there is something that we could do for these patients.
Mm-hmm.
Or physicians that are in a hospital and know about physical therapy, they think of us as, oh, we're people who get people up after surgery and get them walking, or see people
Mm-hmm.
after a stroke that have, hemiparesis or something. And they're thinking, well, that doesn't apply to any of my patients, right? My
Mm-hmm.
patients are really functionally pretty independent. They just have these restrictions, or, they just had a baby, but they can get up out of bed without assistance. So they don't really need therapy. So providing that education that, we do a lot more than just help people who are, if you can get out of bed independently, you don't need therapy, right?
Mm-hmm.
We have a lot more value there. And I think in terms
Absolutely.
of activity restrictions, you know, that's definitely a longer game, providing like in services and articles to doctors, and even going and doing talks at like med schools about
Mm.
sort of the current recommendations. But in the short term, I think even just talking to a doctor about like, hey, whatever whatever restrictions you think are appropriate in your professional opinion, I
Mm-hmm.
can work with your patient within whatever they are. I mean, I saw
Mm-hmm.
that lady in Trendelenburg, right?
Mm-hmm.
And we did do movement right together.
Mm-hmm.
So letting them know that like, hey, I can work with your patient no matter where they are, and I can make sure that they are safely doing their daily tasks within the restrictions that you want them to have. Like I'm on your team here,
Right.
and
Right.
I know that what I'm doing is I am maximizing the amount they're doing, like, right up to that restriction that
Right.
is
Right.
ordered, and making sure that they're really going as far as they can physically to minimize the negative effect
Mhm,
of their
mhm,
restriction as much as possible, right? But I'm
mhm.
framing it to the doctor as, "Hey, like, I wanna make sure that they're safely doing whatever it is you want them to do while being
Right.
able to live their life. Like, for example, I've had a patient that, she was put on bed rest with bathroom privileges, which means she's supposed to be in bed pretty much all day, but she can't get up and walk to the toilet and walk back to the bed. And I went in to see her and she's walking laps in her room. And her understanding was, well, I'm allowed to walk that distance, the bed to the bathroom, 10 feet or whatever it is. So if I've been cleared to walk that 10 feet, that means I can walk that same 10 feet over and over again all day.
I love the idea that you said when you talk to the doctors that like we're part of the team. Like I'm on your side. I'd love
Mhm.
to kind of help and let's maximize within this restriction. I think that's a good maybe conversation starter. Is coming up to the doctors
Mhm.
saying like, okay, I understand there are these restrictions. I'm wondering what I can do in terms of kind of coming up to that limit.
Yeah.
I think that we can try maybe sitting at the edge of the bed, or we can start walking this certain distance without breaking those
Yeah.
restrictions, right? And then and just staying there, I can come in and kind of address some of the postural or the
Mhm.
positioning issues for the patient while they're in bed. Maybe kind of talk about in terms of posture while they're moving. Now it's more of like a team, like
Yeah.
team science, right? It's a
Yeah.
team-based approach rather than my opinion versus your opinion.
Yeah. Well, and even exercise. I mean, I am doing exercise with these patients, right? Now,
Mhm.
some people, like maybe my Trendelenburg patient, the exercise is more active range of motion,
Uh-huh.
but I'm also issuing TheraBands to people. I'm doing sitting exercises. I'm doing standing exercises, depending on what their level of restriction is.
Mhm.
So it's not just, bed rest, straight active range of motion exercise only, right? It's looking
Mhm.
at their restrictions and deciding, with your skilled assessment, what level of exercise could they probably be doing within the restrictions they have. And again, going up to the max that restriction allows them so
Mhm.
that they can minimize the losses they're going to have from being on
Right.
bed rest. But I also talked to the doctor about, like, I'm not just doing movement and exercise, right? I can also address orthopedic pain, which
Right.
is really common during pregnancy, right? To have
Mhm.
aches, pains, radiculopathies. And it's also really common for people who are on bed rest to start developing aches and pains. So these people are
Right.
having like a double whammy of developing pain. And we can totally treat that. So I find myself doing, like you were saying, a lot of positioning stuff, right? If you're going to
Mhm.
have to be in this bed, what are things we can do to minimize the symptoms you're having that are uncomfortable? But then also, I do a lot of what I would consider more outpatient ortho stuff, right? I'm doing manual therapy on people. I do a lot of joint
Manual
mobilizations, a lot of,
joint mobilizations on
yes,
acute care? What?
I know. I mean,
We
I
do
don't
that?
just
No,
do that. I
we
know,
should
I
do
know.
that.
We do
Absolutely.
that, right? And I don't just do it with pregnant patients. I mean, I do things like that in every unit, but
Right, right, right.
it's really valuable for this population. I mean, there's no reason you can't, do manual therapy work like on their low back or on their glutes or, on their lower extremities or their arm or even their cervical spine, right? Because I do see a lot of people that have like neck pain and kind of a radiculopathy down their arm
Right,
going on.
right.
You can do all of that on these patients, right? Their
Mhm,
restrictions
mhm.
don't keep you from doing those types of
Right.
interventions or doing, exercises or movement patterns to help, with whatever pain complaint they're having. And
Mhm.
then, I also work a lot with them on their pelvic health, right?
Mm,
Because
mhm, mhm.
I mean, during pregnancy, right, your core, your pelvic floor, they really get it because
Right.
that you have that baby growing in there. There's a lot of changes that happen there. So working with them on things like intra-abdominal pressure management,
Mhm.
with mobility tasks, with the exercises I'm giving you, with toileting tasks, so that you're
Mhm.
not, bearing down into your pelvic floor, which isn't as good for your pelvic floor health. Also, I find that's something that doctors really like when I talk about, because part of why they're prescribing these restrictions, especially bed rest, is because the idea is that, well, if you're laying down, gravity is kind of keeping that baby from pushing down onto your cervix and down into your pelvic floor,
Mhm, mhm.
which they're hoping will delay delivery, will delay you
Right.
going into labor. So when I talk about, well, I'm teaching them techniques to make sure they're not bearing down into their pelvis when they're
Mhm.
doing activities, they're like, "Oh, well, that would be a good thing, right? Because that's what I want by prescribing these restrictions, is to decrease the amount of pressure going down into that area." Um,
I see.
and then I also do birth prep with people. I know that's more of a pelvic health specialty, right? Is talk, more than maybe acute care, but they are going to have a baby at some point,
Right,
right?
right.
So talking to them about, well, is the plan for them to have a vaginal birth? Is the plan to have a C-section? because sometimes they already know what the plan is,
Hmm.
and providing them education about, different positions you can give birth in, or breathing techniques during a vaginal birth, or talking to them about, this is what happens during a C-section, right? These are
Hmm.
the
Hmm.
tissue layers that are affected. And then we move into preparing you for postpartum. I actually really
Hmm.
like working with the antepartum high risk patients, because when I see someone postpartum in acute care, I'm seeing them like one time, probably, maybe two,
Right.
and I have a 11 billion things I want to talk to them about.
Right. Because you have to
But
squeeze in to that
yeah,
one
you have to
person.
like
Right?
prioritize. But if they're going to be on antepartum for a month, that's
Hmm.
a lot of time for me to do postpartum education and
Yes.
preparation,
Yeah.
whether you're going to have a vaginal delivery or C-section, so that after you have that baby, you're ready, right? From day
Right.
one to get up and move around, to do your tasks in a way that's beneficial to your healing tissues as opposed to harmful to them.
Right. This management of expectations that like these are we can
Hmm.
do that. I mean, we see that with again like elective joint surgeries. There's some type of education in terms of management of
Hmm.
expectations. This is what's going to happen after the surgery. And I mean, why do we not do this? I mean, it is a surgery. There is trauma that's involved. Why do we
Yeah.
not do this? With this population. So back to your patient that was walking to the bathroom. So what was your intervention for her? Did we have to decrease the amount of time that she was walking, or in terms of
Yeah.
the laps that she was doing within her room?
So with that, you know, first, I mean, you should talk to the doctor and the nurse to clarify, when you say bed rest with bathroom privileges in her chart, this is really what you mean, right? Because I mean, those terms aren't written in stone somewhere,
Hmm. Hmm.
right? It's like partial weight bearing. Like some doctors say that means 50%, some say it means 25%. I mean,
Hmm.
you need to clarify, what does the doctor really mean? I mean, maybe
Right.
the doctor did tell her, you know what, you can walk laps in the room as long as it's no more than 10 feet at a time. I
Mhm.
mean, maybe he did. I don't know. Right.
Right.
So clarifying with the doctor what they really meant. And this doctor really did mean, no, she can only go to the bathroom and come back to bed. I don't want her walking laps. So having that conversation with her that, hey, your restriction is this, and
Mm.
that means that your doctor doesn't want you doing these laps. I am here to work with you to figure out what's the maximum amount you can do in terms of exercises and walking around. But also, understanding your patient does have autonomy, right? If she decides, well, you know what, I think I can still walk and I feel fine. I mean, she
Mhm.
can do that, right?
Right, right,
Just like your non-weight bearing patient, if you explain to them why they're supposed to be non-weight bearing and they
right,
decide, I'm not doing that,
right,
I mean, they're adults, they can do that, right?
right. Or the high risk falls
And
patients that are getting up
yeah.
on their own. It's like they're gonna sometimes break those restrictions. And another thing I want to ask you is that what are some common restrictions? And this is funny because I'm like, oh, no wonder now it clicks. Like they're in Trendelenburg, so there's less pressure, in terms
Hmm.
of in terms of like where the baby's at positioned at. But what are some of the other restrictions that you run into working with this population?
Yeah. So the Trunellenberg one is the most severe one, and you rarely see that
Hmm.
anymore. I mean, I've
Hmm.
seen it like twice,
Okay.
probably in like 8, 9 years. Much more common. I'd say the most common one I see is bed rest with bathroom privileges.
Okay.
So, right, like the lady who was walking laps in her room, where they want you to be spending basically all day in bed, but you are allowed to get up and walk the
Hmm.
distance to get to a toilet, go to the bathroom, and then walk back.
Okay.
That's probably the most common. You may see people that are told they're on bed rest, strict bed rest, which usually means they're supposed to be in bed and use a bedpan,
Wow.
but they don't necessarily have to be in Trendelenburg. But you can
Mhm.
also have people who just have any amount of restriction less than their normal activity, right? Where they're being told, okay, you can't exercise anymore, but you can go on walks, you can do
Okay.
light housework, you can sit, right? You
Mhm.
don't have to be laying down.
Mhm.
It's
Mhm.
really, really broad, right? So anything from in bed all day to just tone it down from whatever you normally do. You can be anywhere in there, which is why it's important to clarify with the doctor, what are they really expecting
Right,
for
right,
this particular patient, right?
right. Excellent. And
Mhm.
then again, the teamwork approach in terms of so that everyone understands what's going on. With the left hand is
Mhm.
saying to the right, that we're all
Yeah.
on the same page. Aaron, do you have any interesting kind of stories about you as a physical therapist that what the value you're able to bring into that specific case in terms of educating a patient or educating a doctor or a family member that without your services it could have gone, it could have been very detrimental for the patient.
Yeah, I mean, I think that the orthopedic pain interventions I provide make a huge difference. Patients go, "Oh my gosh, I feel so much better."
Hmm.
Right? I mean,
Hmm.
they're already dealing with the stress and the fear of a complication. having to be in the hospital and leave their life outside the hospital behind.
Mm-hmm.
And if you add on to that, that like my back is killing me
Mm-hmm.
or my neck is killing me, providing them with that relief can make a huge difference and can help them even with things like being able to sleep, right? Which is really important for
Right.
their mental and physical health. I also think that one of the valuable things that we provide is helping people manage the fear and the stress that moving their body could kill their baby.
Mm-hmm.
So I know that's something that I dealt with a lot during my pregnancy with complications. Is there's just this
Right.
you can't see what's happening inside your uterus from the
Yeah.
outside, right? So there's this constant fear that I might cross some invisible line
Mm-hmm.
that I
Mm-hmm.
can't see, I don't know where it is, and I do too much, and now my baby's in trouble.
Mm-hmm. Mm-hmm.
Right? So being able to be with people and walk them through this is what your restriction really means. These are the activities you can do. These are the things we're going to monitor for that are early signs that maybe we should rest a little bit. And I'm going to be here with you as like an expert to just help make sure that everything is okay
Right.
while we are doing whatever we're doing.
Mm-hmm.
I think that makes a big difference with helping to reduce the fear and anxiety.
Right.
And there's also, I mean, when you were talking about earlier that acute care therapists, we do a lot of problem solving,
Mm-hmm.
right? A lot of creative problem solving around things that aren't necessarily about movement sometimes. For
Mm-hmm.
example, I had a patient that, I always ask, how are you sleeping?
Mm-hmm.
Because people don't always sleep good in the hospital, right? And I had a patient who she's like, I just
Absolutely.
can't sleep.
Mm-hmm.
And, the next question I always ask, just like with pain, is like, well, why can't you sleep? Like, what is going on? Is it people coming into your room? There's like noises out there. Is it pain? Do you have pain somewhere? You can't get comfortable. And she told me, well, at home, I sleep in the same bed as my partner,
Mm-hmm.
and we always sleep touching each other.
Mm-hmm.
And here I'm sleeping alone in a hospital bed. And
Mm.
her partner was staying in the room with her because they had come in, I think, from out of town. So he was actually like sleeping there. But he's sleeping on the pull-out couch thing
Yeah, or like the
across,
chair, the
like,
recliner, right?
yeah, it's across the room,
Yeah.
right? And I said, okay, this furniture isn't glued down. We can move the couch he's sleeping on to be right next to your bed, put the
Mm-hmm.
bed rail down, right? Adjust the height of your bed so it's flush with the couch that he's on.
Yeah.
And then you
Mm-hmm.
guys can sleep next to each other again.
Mm-hmm. Mm-hmm.
And she was like, we can do that?
Right.
And I said, yeah, this furniture has wheels. Like we can we can do whatever we want, right? Like we can move it around. But little things like that can make a huge difference for patients. And
Absolutely.
I find that
Absolutely.
acute care therapists, PTs and OTs are really good at asking those extra questions,
Yes.
right? When someone tells you, "Oh, I'm not sleeping," or "Oh, I'm having pain here," asking those follow-up questions about like, "Well, how long has this pain been going on for you?"
Mm-hmm.
Right?
Mm-hmm.
Asking, "Well, does it radiate here?" Right? Does anything make it better or worse?
Mm-hmm.
And then being able to problem solve around all of that to come up with a solution for people is something I think that's really valuable. And
Yeah.
and that is something that it's hard to put in like a little flyer that you
Right, right.
right, that you're
Exactly.
handing to a doctor that says like, "I'll make sure they know their activity restrictions, and I'll treat their orthopedic pain, and I'll do birth prep." But little
Mhm.
things like that, like, I'll pull the sofa over so she can sleep
Yeah.
next to her partner
I
so
mean,
that she can get good sleep, right, is not
absolutely.
something that's gonna go on a flyer.
And I'd say who's better than physical therapy to be able to rearrange furniture? Because we do it all the time. When I go into these
True.
patients' rooms, it's like, how are you going to get to the bathroom? We're going to have to move these
Mhm.
bags. We're going to have to move this chair. We're going to have to move this table. So I think that's absolutely a fantastic intervention. And just thinking
Mhm.
about that in terms of problem solving, like it's not glued. You're right. It's not glued down. We can move this over, shift the tray table over, and put that
Mhm.
right next to you. I think that's such a cool story to hear that. And that is so true.
Yeah.
I can see that happening on the floor. Is that, but you never would have had that opportunity had you not been consulted for this patient, or if you hadn't asked the question, how's your sleep? So very cool
Yeah.
stuff. I think it's
Yeah.
time. We're gonna go for our rapid response round. Are you so? I think you've been here before. All right, Erin? We're gonna time you. We're gonna give you maybe about a minute, give or take. Let me set up my timer. Rapid responses. You've been here before, but you had a group setting. Now all the attention is on you.
Yes.
All right.
Mhm.
All right, Erin, we're ready for our rapid response round. Okay, we're going to do about a minute. You ready?
Yes.
All right, and let's get started. What color scrubs do you like to wear on acute care?
My favorite color is teal.
Teal. Very
I
cool.
like
Awesome.
light teal. I like dark teal.
Very
It's a good
nice.
color for me.
Awesome. Uh,
Ooh, probably ice cream.
ice cream. Fantastic.
Yeah.
Do you have any good book recommendations?
Oh my gosh, book recommendations. I'm panicking. I'm panicking.
Or how about
um, I
go ahead.
I do really like to read. I do really like to read. What am I reading right now? I'm trying to remember what it's called. It's a
APT
parenting
Secret
book, so
Journal.
it's not super exciting. It's not anything super exciting, but oh, well, I can tell you my favorite book.
Sure.
I can tell you my favorite book, Love in the Time of Cholera by Gabriel Garcia Marquez.
Very cool.
My favorite book. I
Awesome.
read it like once a year. It's my favorite book.
Awesome. Are you a morning person or a night owl?
Night owl.
Night
I would
owl.
like the world to start at 9 a.m. 10 a.m. maybe.
Android versus Apple.
Apple.
Apple. Okay. And finally, last question. You're working on acute care when, fill in the blank.
You can treat everything. You go from a cabbage to a knee replacement to a stroke to a pregnant patient.
A pregnant patient that's having difficulty sleeping, and it's just a matter of
Yes.
rearranging the furniture. Fantastic. Thank you so much, Erin, for joining us on the podcast today. Where can people find you if they have questions, if they may be thinking about, I would love to get into this,
Yeah.
working with this patient population? How do I even start? How do I initiate this conversation? Where can people find you?
So you can find me on social media, Instagram, Erin Locati _PT. I also am the admin for a Facebook group, if you're on Facebook, called OB, PT and OT. OB is short for obstetric. It's a really great place to connect with other therapists that work in this space. And we have a Google Drive associated with it with a lot of free resources for people. That's actually how I got started, joining this group and like asking people questions. And then I also do have some continuing education stuff that I run for people for high risk pregnancy and then also for super early postpartum. Right now, they're hosted on Embodia
Mhm.
and also the Pelvic Health Network. But in April, they are going to be on Pelvic Global.
Mm.
And that's something I'll post on my social media whenever it comes on there. But when it shows up on Pelvic Global, it should have CUs for PTs and
Ooh,
OT. Yeah,
nice, nice.
it's a big deal, right? Because
Mhm,
currently I have CUs for my courses approved in Texas, the state I'm in. And then if you're in
mhm,
any state that accepts Texas CUs, you could get them, but it's only for PT and it's
mhm.
not every single state. So that'll be pretty exciting in April when Pelvic Global starts hosting my courses because they are helping me get CUs for PTs and OTs in all the states.
And all the states. Fantastic.
Yeah.
Awesome. Awesome. Well, Erin, thank you again for being part of the conversation today. It was a great conversation. And thanks again for doing everything that you do and then, informing our audience of the great opportunities that you might be able to embark upon in terms of working with this patient population. Thanks so much.
Yes, thank you. Thank you for having me.
We would like to thank Erin for joining us on the podcast. Acute Conversations is the official podcast of APT Acute Care. It is hosted by Leo Arguelles, executive produced by Katie Rado and Edward Mathis. Music by Alexia Action from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another engaging conversation. Thank you for listening, and may your shoes and scrubs stay clean today.